All right, well, thank you. So I think we're back on slide 43, at least that's where I would like us to be. And let me add my thanks for your continued attention and engagement. I know it's a lot of hearing from the same person, so thank you for your patience. And I hope we can continue to have the robust discussion that you all have started. So now that we've cataloged the many different features of our healthcare delivery and finance system and gone through some of these significant challenges that define that system. And we've linked those back to the complex and fragmented ways that we arrange and pay for care. I wanted to turn to reviewing how different participants in the system influence the outcomes that we all care about. So the focus of this section is to ask ourselves, who's in a position to improve affordability or quality or access or equity? Who holds that kind of leverage? Or who's in a position maybe to get in the way of efforts for positive improvement in those areas? And then where are those actors' interests and concerns aligned, and where do they maybe come into conflict with one another? So in this section, we're going to spend some time first talking about what I call market participants. That is the people who are in organizations, the organizations and people who are making market transactions in the delivery of healthcare. So that'll include these four categories: healthcare providers, plans, purchasers, and consumers. Then we'll go on briefly to the policy and regulatory levers and areas of influence. And finally, these questions about sort of what's the responsibility or the impact of public, the societal contributors. Next slide, please. So beginning with healthcare providers. So here I'm talking about primarily the doctors and hospitals that are in decision-making roles around delivering direct care. So these are the actors who deliver care and make decisions day in and day out that influence what sorts of services and interventions consumers receive. They make decisions about how frequently consumers receive services, how intensive those services are, how much testing and screening occurs, and myriad other services. So they're on the front lines, as it were. Their actions influence the extent to which care that is delivered is appropriate or sometimes unnecessary. And like all market participants, they respond to their surrounding financial incentives. So everything else equal, and it never is, they will provide more services when those services are associated with greater financial rewards, and fewer services if they aren't rewarded or if they're even penalized for delivering those services. So when you consider the ways that provider choices currently affect health outcomes in worrisome ways, that might include, as we've previously talked about, the ways that they exert market power. In areas where hospitals are few and they command this must-have status with health plan negotiations, they can drive up reimbursement rates that contribute to excess healthcare spending growth. When you consider about the potential for provider actions to influence positive system outcomes, those include things like improving access to services by moving into some of these shortage areas, or welcoming uninsured or Medi-Cal enrollees to a greater extent. So again, this is from a system-wide perspective, what can providers do to make things better? They can improve efficiency by accepting capitation or other reimbursement rates that once again reward coordination of care and don't provide incentives for more volume with dubious benefit. They can improve quality by assuring that evidence-based guidelines are used, or working in a practice setting where their peers hold them accountable for quality outcomes. And they can invest in IT systems, which makes it easier to manage care for a whole population over time instead of just engage in sort of sporadic delivery of services to the patient right in front of you. So while CalPERS's large membership and the commercial health plan networks and reimbursement rates that you offer mean that providers are generally eager to serve CalPERS members, it is important to recognize that particularly in some market areas, providers are in a strong bargaining position with CalPERS, and your influence over them can be indirect and somewhat limited. So providers have a lot of say in who they serve, what organizational home they work in, and with whom to partner under what circumstances. And so their role in the healthcare system is certainly a significant one. Next slide, please. Turning now to health plans. Health plans are the actors that serve as intermediaries between purchasers like CalPERS and Medi-Cal and other commercial payers and providers. They collect money from purchasers, they enroll consumers, and enter into contracts with providers for covered services so that those services are paid for when they're delivered. Health plans actions influence the range of providers that are in networks available to consumers. And in managed care arrangements, they play a role via things like utilization management and approval processes and the design of formularies. They play a role in defining the treatment options that consumers can access within their coverage. Again, like all market participants, health plans respond to the financial incentives that they face. So for example, health plans will seek to enroll populations whose use of healthcare services is relatively stable and predictable so that they know that if they set premiums, those premiums are likely to cover the claims cost. In our system, health plans are also the entity that regulators and purchasers can hold accountable for access to care and quality outcomes. So because they aggregate many people into these contractual relationships, generally the responsibility for assuring access and quality is focused on health plans, although they may in turn delegate that into their provider partners. When you consider the ways that health plans currently affect system-wide outcomes in worrisome ways, their financial incentives and business models cause some to gravitate toward areas of the state or populations that tend to be healthier or lower cost. So risk adjustment, which I know CalPERS is in the process of reinstituting, is a way for purchasers to prevent some health plans from benefiting from their ability to attract healthier people, while others disproportionately bear the costs of sicker people. Another concerning outcome can be health plans if they seek to differentiate themselves or break through into low-cost markets. They may layer on additional administrative burden for providers by just additional plan reporting and contracting burdens, even though they aren't otherwise much differentiated from other health plans. When you turn now to the ways that health plan actions could influence positive system outcomes, these include structuring networks that balance access with cost or efficiency. So thinking not just about having a network, but having a network that is really responsive to consumers' needs and is efficient or delivers the best value for the money. Another way health plans can be a positive influence is in streamlining or standardizing reporting requirements. So they can reduce how much they demand from providers, or perhaps better, they can assure that what they request of providers works well within the provider context and is consistent with what other regulators or plans are asking. So CalPERS' large membership makes it an attractive customer for health plans, particularly health plans who are seeking to serve low-cost markets. There's a question, which I think your team has researchers looking into, about what the right level of competition among health plans is. The use of health plans as intermediaries has benefits in terms of network design and access to providers and some of these aspects of accountability, but those need to be balanced against the potential burdens on providers, possible confusion among consumers, and complexity that more and more choice may bring. Next slide, please. Turning now to the role of purchasers broadly in the healthcare marketplace. A key role for purchasers is that they pool consumers or members who are diverse in terms of their healthcare needs, their age, and many other characteristics that influence how much healthcare they need. And then they contract with plans on behalf of their membership. So employer purchasers like CalPERS represent groups based on employment, obviously. Covered California negotiates with plans on behalf of Californians who don't have an employer offer of coverage. Medi-Cal contracts with plans to serve low-income Californians. Large purchasers are the customers of health plans, making it possible for health plans to market and contract in much more efficient, lower-cost ways than they would if they had to attract and manage customers one by one by one. So I previously spoke about how providers and plans can sometimes, in response to their economic incentives, affect outcomes in worrisome ways. Purchasers aren't subject to the same direct financial incentives that plans and providers are, but they are constrained by mission or structure to prioritize their members' and employees' needs over others. So this can lead to market segmentation that allows those widely different provider payment rates, different standards for quality, and so on and so forth. So turning now to how purchasers can have a positive influence on system outcomes. These include things like implementing reimbursement strategies that reward higher quality, more efficient services and settings of care. And again, I'm aware that CalPERS has done some of this for things like reference-based pricing and the use of centers of excellence. They can structure benefits to begin with lower cost treatments before moving to more costly types of care. So Don shared with me the biosimilars first notion that you start with a less costly intervention if it has a good chance of being equally effective. These are strategies, again, that you've pursued, I know, in your self-funded arrangements especially. There are, so those kinds of approaches try to affect better outcomes for particular patients in particular circumstances. There are other important ways in which purchasers can look broadly at the role that health plan partners play. This goes to the question in the conversation that we had about coordination of care and integrated healthcare delivery approaches. So working with HMO partners that are deeply invested in population health management can be a way to assure quality of care, better quality of care across a whole population, and better address the whole array of consumer healthcare needs, as opposed to some of these tailored reimbursement strategies that are also important, but affect a more limited share of the population. Next slide, please. So consumers' behaviors and choices also play a role in what healthcare services are needed and sought and provided. But in our system where there are so many intermediaries, those options are constrained and determined by factors outside of the control of consumers in many cases, maybe in more cases than one might first guess. As we saw on that earlier slide that we talked about in the last question and answer portion, many of the forces that influence people's health emerge from socioeconomic forces and structures, the lack of investment in social needs that go far beyond individual behavior and can't be solely addressed either by their actions or by the healthcare delivery system. Another consideration here is that because medicine is so specialized, consumers rightly rely on the expertise of medical professionals to advise about what services are appropriate, where to get them. So the areas in which consumers have agency, where they really act on their own behalf and make decisions completely unencumbered, are relatively limited. So as listed here, consumers do choose which health plan and product to select among the options that are made available by the employer group or the program that arranges coverage on their behalf. They choose among providers within their plan's network. And in consultation with medical professionals, they decide whether or not to accept or pursue different kinds of treatment, how aggressively to treat certain conditions, for example. Again, we have a specialized and highly expert healthcare system where there are many amazing treatments available for many types of care. But more is not always better. And when patients and their advocates have a role in learning about their options and really evaluating them with trusted sources of information, sometimes choosing care that's less intensive and less costly yields similar or better outcomes. This can happen at the end of life. It can happen with certain kinds of cancer therapies. I will note that it's important to offer these options in a trusted context to consumers so they can evaluate their choices. There isn't a lot of data that including data on relative prices or costs that causes people to shop and move around from one provider to another, because people do rely so much on the recommendations that they get from the people within the healthcare system that they trust. So in sum, it's important to acknowledge that consumers are important actors in the healthcare system. Obviously, better healthcare for people, for these consumers, is ultimately the reason that any of us is involved in these conversations and works on these issues. But to move healthcare outcomes on a system scale usually requires intervention at a much more aggregated or system-wide level. Next slide, please. So that brings us to the areas of policy and the regulatory sphere. Policymakers and regulators play the role of setting rules for market interactions. And they also have a role in allocating resources from public budgets to healthcare and to social services, and indeed decide how all of our public resources will be allocated. Policy and regulators set minimum standards, including the services that must be included in a covered package of benefits. In some contexts, for example, in the federal Medicare program, and in some other countries, the policy sphere is where provider payment levels are set, or even in our current situation, there are sometimes some constraints around the way that the level that health plans or providers can charge. So for example, under the Affordable Care Act, there's a limit on how much administrative overhead versus medical claims cost can be built into a health plan premium. So policymakers and regulators have a role in setting kind of the rules of engagement, but in this diverse market system, those rules more are about setting the rules of the game rather than influencing the outcomes directly. I would note here that, of course, policymakers don't make their decisions in a vacuum. The voices of plans and providers, consumer advocates, and purchasers influence the outcomes of public conversations. So organizations such as CalPERS need to stay informed and, of course, do and should continue to engage in public conversations around those rules of engagement, how they affect you and your members, as well as how the system is working for Californians overall. Next slide, please. Finally, there are areas of influence that emerge from our broader societal context. This is the slide I was alluding to in response to Ms. Middleton's question about COVID and what have we learned. These broad questions about how much we invest in healthcare and how much we invest in social determinants of health have lasting and important implications for health outcomes and for equity. To the extent that we have longstanding problems in this country in assuring people equal opportunity, regardless of their race and income, those play out in terms of healthcare outcomes. to the extent that we have embraced sort of a blame the victim mentality, or a sense that each of us is alone responsible for our health or our well-being, as contrasted with a more collective mentality that we share responsibility for one another and we're all in this together, those two affect the quality of life and health. And so, next slide, please. I will add here that in this very fragmented healthcare delivery system, the way it's really not clear in this hybrid public-private system whose role it is to influence some aspects. No one entity or collective process owns a shared vision for how costs are spread and risks are pooled, how resources are allocated and distributed. Instead, these tend to be the residual outcomes of a largely market-based program and a patchwork program of delivery and financing for healthcare, rather than the result of any intentional priority setting. So by this, what I mean is we make decisions from the bottom up. Rightly so, if this is your role, what benefits should be covered? What prices need to be paid in order to access certain services? And then that's what adds up to how costs get spread over different populations and people and how resources are allocated. It's really inevitable that this is the case when we have so many different decision makers and actors in the mix, but it can make it challenging to bring about positive system change. Next slide, and summing up this section, these different actors play different roles and they exert different types of leverage on the healthcare system. My hypothesis going into our final section, which I believe is going to be after lunch, is that decision makers have the greatest impact when they focus on those areas where they have particular leverage, yet do it while understanding how other actors are behaving and the incentives to which they are responding and the missions that they are seeking to advance. So let me conclude there for this section and again, invite any questions or comments.
Mr. Rubalcaba.
Thank you, Mr. Jones. Again, a very informative presentation. Thank you very much. I wanted to talk about 2 points that you raised. First, on the section around the health plans, you were talking, there's a bullet about how to design health insurance products and benefits. And the goal of, you mentioned is, how do we deliver the best value? And you mentioned some of the strategies, risk adjustment, to drive. But one thing I was hoping, based on when I first saw the bullets, I thought you were going to address in more detail neural networks, and it wasn't really discussed because, I mean, that's also one way to deal with something we talked about. You mentioned earlier, the chronic disease, health management, I guess, managed care. And in neural networks, they have the promise of quality by making sure that you get a primary care physician who really takes on the patient's well-being. And it has that cost value of I forget what you call it, when you have the regular monthly payment. So
right.
So there's an incentive. There's a financial incentive to keep your patients healthy, so they don't go into the hospital. And the hospital will be my second question. We'll get to that one about consumer behavior. So I was wondering if you had a comment about that, because I think the whole thing about neural networks, why they are attractive to me, seem interesting. They also have something that you mentioned in the first part, which is the whole thing about depending where you live, you also have access issues. So I was wondering if you could speak a little bit to that plan design. Health plans and I see them, they're trying to create these neural networks and all what have you with integrated care, and yet is very, I'm not sure what the future holds for them, but if you could speak to that, please, Ms. Mulkey, and then I'll get to another question. Thank
I'm not sure what the future holds either, but I appreciate the question very much. So I would distinguish again. I hope this doesn't sound like a broken record between integration and clinical network development. Thoughtful, so population management, having a population of covered lives for which an integrated set of healthcare providers are responsible. I think that's hugely important for many reasons, including quality and cost. And that it puts the incentives in the right direction, as you described, that the incentives tend to be, we are responsible for this population's healthcare over time. Therefore, we have no incentive to prescribe services just for the sake of prescribing services. Instead, we have an incentive to provide the care that's needed, but yes, so no incentive for excess treatment in any case. Narrow networks can mean different things. When Covered California rolled out, they developed some products that were narrower networks than many of the HMO products available on the market at that time in California, and had a particular focus on lower cost providers. Because when consumers pay the full premium, premium is hugely important, and those lower cost providers could make a big difference, especially if you're aiming to take a few of the very highest cost providers out of the network in order to focus on that. But narrow networks can also be seen as a concern or a pejorative term if they are seen by consumers as restricting choice or access in locations where there aren't a lot of options right now. So I think it's a very important technique, and I might, my friendly amendment might be to talk about the huge potential for network design to have positive impact, and kind of leave it for more nuanced conversation about whether you call that narrow or whether you call it something else. But I think your issues, your comments are right on the mark in terms of the financial incentives, the desire for population management, the alignment of incentives, and then the way that those overlay with network design.
Yeah, this is Marta. Go ahead.
No, we always want to talk at the same time. You go ahead first.
Yeah, all I was going to add is just to put a finer point on it. A narrow network with a fee-for-service benefit design or a fee-for-service reimbursement design doesn't do anybody any good, because it doesn't align the financial incentives to ensure that the appropriate population management occurs. And so I think that, you really need to combine the population health management that Marion's talking about. So that integrated healthcare team with your primary care provider, plus your specialty networks for referrals, plus those hospital systems that have the right financial incentives to keep you out of the hospital and care in the lowest acuity settings. That financial package, that reimbursement package, with those incentives, that's what gets you to the high efficiency care. But to just pay people for volume, but reduce the number of people that you pay, that does not get you to efficient care. So it really isn't about the breadth or narrowness of the network, but instead about the financial arrangements between the payer and the providers.
And I was gonna add two other points. The first is that there was a lot of anxiety after the Affordable Care Act was passed because the marketplaces, Covered California and their equivalents in the rest of the country, were doing what Covered California did, which was to go to much narrower networks as a way of delivering care at a lower price point. The polling, by and large, showed that consumers of healthcare do not notice a big difference in the quality of the care or even access. So by and large, they were as happy in a narrower network than they were in a broader network. So that's point number one, which suggests that they're very promising. The challenge is that narrow networks are work in the places where we have the lowest cost already, and there are challenges in the places where we are trying to curb costs. So it's very difficult to construct a narrow network in Alpine County. Considerably easier to construct a narrow network where you have a lot of competition in places like Riverside or Orange County, where there are a lot of options and you can actually use it as a tool for driving costs lower. But in these single hospital counties that we talk a lot about, in rural areas where there are limited providers, it's not as effective a tool for reducing costs.
Thank you for both, all three of you for responding to that question. I think you also touched on something that was, well, the consumer and their perception of choice and all that, I think fits into my second question, and that's consumer behavior and how they choose. I think Ms. Olivares mentioned something about the role of advertising, I think in the pharmaceutical area, but you see that also in the hospitals, and it's usually the high-priced hospitals that spend a lot on advertising. And so that influences the consumer, and so that drives them to certain medical groups that have the relationship with the hospital. And so I'm not sure that actually is a better value health-wise. And so the question is, can there be policy intervention where it minimizes how much branding you can do? Because I noticed that the people who really focus on branding are the health plans. But unless you know what plan you're going to, but it doesn't, but what plan A versus plan B or insurance carrier, the network, I mean, depends who the employer from, say we're talking CalPERS. Just because you choose plan A, insurance plan A or plan B, it doesn't mean, you have to compare it based on network and level of benefits, but you don't get that from the ads. They just get a name recognition. I want this brand A versus brand B, but you don't know if you're comparing apples to apples or oranges to prunes. So the role, I guess the question is, I don't see anything policy-wise about educating the member, the consumer, about how to pick. You made some polling. I wasn't aware of any polling that they could not tell the difference between narrow or full. And I guess my question is, what role can we have on the policy side about educating, and can advertising be restricted somehow so it's educational versus just picking a brand? I'm not sure if that's viable question or not.
Yeah, I mean, I think, so I would say a couple things. I think that this image and this must-have status and the grounds on which providers compete sometimes are not clearly linked to value or outcomes of a clinical sort, or even perhaps a patient satisfaction sort. In a fundamentally market-based context, I find it a little hard to imagine severe restrictions on marketing for healthcare entities as opposed to all the other things that market to us. And I think consumer education is a totally laudable goal, but is hard to achieve. So I think mostly what I'm saying is I feel your pain, but I don't have any constructive solutions to offer.
Don and Martha, nobody wants to weigh in on that one?
I sadly agree. I would add pharmaceutical advertising to the same bucket.
Oh, yeah.
Just talking about, and just in terms of what it does, where it pushes people, and its overall value in the healthcare system. Some of those are decisions we made as a country a while ago. Unraveling them is challenging, to say the least. We know they add costs. There have been a lot of efforts, and Marta is more aware of the ones that have happened over the last decade in California than I am, but I know there have been a ton to try to educate consumers about the quality of the hospital that they're going to, just as a way of sort of changing the conversation, less around branding, more around actual data. They're great in that would be great if it's nice to have that information out there. It's important. I haven't seen it make a big dent, unfortunately, in consumer behavior.
Yeah, I would agree with Don. There's all sorts of really high quality data out there on hospital performance, clinical performance by medical group, but it's not often used by consumers. People are busy. They're working, they're raising families, they're doing whatever they're doing, and typically they're not thinking about the healthcare services that they're accessing until the point that they need to access them. And then they're making those decisions based on either word of mouth or prior experiences or something somebody's told them, or, to your point, an advertisement that they saw. So we're going to do everything that we can in the health program to inform choices at the point at which our members make choices, which for us is open enrollment, and provide them as many tools as possible. So some of the tools that we're going to try to continue to make more readily available is, the consumer satisfaction. We're going to come up with some efficiency scorecards for our health plan. So how well they're doing on cost and quality. So we want to make that as available as possible, but I'm not going to make anybody assume that it's going to be more readily used than any of the other information that's available to consumers that isn't used today, because just the way people access the system is they make decisions, when they need to make the decision, which is in the moment, and not typically, with lots of hours of thoughtful research when they pick their primary care physician or which hospital with whom they're going to affiliate. So it's a tough one.
Thank you.
Okay, thank you, Mr. Ruka. Okay, I see no additional questions from board members, so we'll now see if there are public comment. Mr. Fox. Mr. Fox? Cherie, can you hear me?
Yes, Henry, I can hear you.
Can you see if Mr. Fox?
I am.
Okay. David, is Mr. Fox connected?
Henry, we lost connection for a second, but it's coming back online right now.
Okay, thank you.
Mr. President, can you hear me?
Yes, I can, Mr. Fox.
Okay, my apologies. The call-in studio logs you out after 4 hours exactly.
Okay, no problem.
We have two callers. The first will be Tim Behrens of CSR.
Okay. Okay, Mr. Behrens, you have 3 minutes.
Thank you and congratulations, President Jones, members of the board. Great presentation, very educational. I hope CalPERS will continue to work with us, the board and the health team, to help pull down the cost of healthcare plans and medications in the future. I would like to see more time this year spent on incentivizing more preventive programs, which I think can lead to healthier stakeholders, which should help pull down the healthcare cost. Thank you. Have a good day.
Thank you. Mr. Fox.
Yes, Mr. President, we have one more caller. I don't have a name, but they're from RPEA.
Okay, thank you. And you have 3 minutes.
Under RPEA, can you hear me?
Yes, we can.
Okay, because there's been a little disconnection problems. I just wanted to make a comment that I haven't really heard. I know that you were talking about choices and people having difficulty knowing who to choose in networks and whatnot. I live here in the Bay Area, and I have a little bit of an issue with John Muir Network. They have been gobbling up all these independent doctor systems and programs, and over the past year, they're one of the major networks that kind of developed the whole Bay Area. There's a couple others, Palo Alto, Stanford, I think, here. But one of the issues is that you really, Medicare patient, primary care, and then, of course, the CalPERS PPO plan as a supplemental. There's a limited number of doctors in this area because it doesn't pay enough for them to take care of Medicare patients. But it is so limited. But there are issues. They're very, very controlling. And one of the main issues I've noticed, and they said they're changing as of the first part of this year, but you can't even get a copy of your medical report. How can you really help manage your own health when your own doctor's network will not share a report of your visit? All they do is give you a visit notice of all the medications you said you already take. They do not list what's a problem. They don't list how you, nothing. They don't tell you anything about your report of being there that day. And they said, well, we can send it to another doctor for follow-up. I go like, I want to see that report. So I have an issue, and I don't know how CalPERS can get involved. You want us involved to help do our own health care in terms of, what we can do. But when you don't even get a medical report from the doctor's office, that's wrong. And then they said when they start this new program, you can't get anything from the past. You're not going to be entitled to it. I think this is very controlling, and this is not to the best interest of the patients. So I don't know if this should be something you should be aware of. Thank you.
Okay, thank you for your comments. And Mr. Moles, I don't know if there's a way for her to follow up with you on that issue. Mr. Fox, if somehow you could connect the speaker so that you can get a response.
I'm happy,
Okay.
to follow up with her.
Okay, thank you. Okay, Mr. Fox, are there any additional requests to speak?
No, Mr. President, that concludes the public comment for this portion.
Okay, well, thank you, Ms. Mulkey and Mr. Moles and Ms. Green for excellent presentation and excellent dialogue and information. So, plus you're ahead of schedule. So thanks again. So in that regard, we're going to take a break for lunch, and we will reconvene at what time is it? Let's say 1 time is it? 1:15. So we'll take a lunch break and reconvene at 1:15. So have a good lunch, everyone.